When we were doing PRP, the first thing we always said was that it's a healing agent and it helped control the infection, right? And that's why we use PRP and PPP. So if this protein's not in PRP, but it is in bone marrow, then that gives us even more of a distinct advantage within that field if we can say that it's got some antimicrobial or
I think not only can we say it has an antimicrobial effect, but we're getting ready to publish that data. I mean, when you plate nosocomial infections or try to plate a nosocomial cause of infection, so there's 9 common nosocomial or hospital-acquired or community-acquired infections. And we have a paper coming out before the end of the year, probably, certainly if not before the end of the year, late fall or early winter, that's going to show that there is a bactericidal effect of bone marrow. It's very difficult, and it certainly reduces the colony counts when you try to plate bacteria on BMA. PRP has some of that same effect, not to the extent of BMA, because PRP has the concentrated growth factors, some of the microvesicle or the trophic factors secreted by the mesenchymal cell that we're able to concentrate from whole blood. But certainly when you compare those to just a regular placebo or the regular auger, there's a dramatic difference in the bacterial colonization in the lab. And that's exactly what we expected to see because of the change in the infection rate we've seen with bone marrow patients. And we have over 1,500 cases in the last 3 to 5 years and haven't had an infection. A heart hospital doing a study right now. So in the study at that hospital, which there is one of the top heart hospitals in the world, and it's in the US, they're doing a treatment and a non-treatment group with bone marrow spread on the coronary artery bypass patients. Their infection rate for the length of their time that they've been doing hearts at this hospital is about 3%, which is considered great for that type of a surgery. They're doing a randomized prospective study using bone marrow aspirate concentrate on the wall of that heart tissue in the coronary artery bypass surgery patient to see if it helps mobilize and restore tissue health faster than just returning the blood supply after coronary artery bypass surgery. And the results are significant. But one of the side effects that they've noticed in the study is that while the non-treatment group, their infection rate is still right at about 3%, just like it always has been, the infection rate in the treatment group has dropped down to almost 0. So they've actually now decided that they're going to continue with the study, but that particular hospital only wants to be involved in the treatment side because they're mandating now that bone marrow aspirate concentrate be used in their coronary bypass surgeries because infection is such a tragic complication and side effect of the surgery. So they're doing everything they can. We do everything we can in surgery to cut down on infection, especially in a heart patient. So now we have an additive procedure that they were doing to help the heart heal faster, the muscle wall. And the side effect they noticed was the infection rate went down to 0. And they couldn't explain that, but it's an independent variable. It wasn't dependent on the surgeon. It's not dependent on the facility. It's dependent on bone marrow aspirate concentrate. And now we know, and Arnie Kaplan, the father of the stem cell, he literally patented the mesenchymal cell in 1995, and Neil Rorden, which is our chief scientific officer now, we've isolated a peptide called LL37. And it seems like, and what certainly is going to be published soon, is that it is an extremely bactericidal agent secreted as a trophic factor, or what Neil describes as microvesicle support. These cells, the mesenchymal cells, secrete these microvesicles of information and peptides and messenger RNA even to dump in to these diseased tissues. And the agent that looks like it's such a strong bactericidal effect is a peptide called LL37. And there's other peptides that are associated with that, but it's literally trophic factors of support produced by the stem cell.
How do you think it's released?
It's packaged and stimulated by those cells in response to a protective response from the tissue that we put them in. They literally find the diseased tissue. What mesenchymal cells, how Neil would describe mesenchymal cell support, or why trophic factors work, is it's one of the most potent anti-inflammatories in the world. And that's why he sees such a difference with the patients that we use these high volumes of stem cells on for autoimmune diseases, because we're reducing the inflammatory response. We're changing the body's reaction. And that's the reason we see such a big difference with non-union fractures, because we're stimulating the body to heal that area. That's the reason we see such a difference with the chondrolytic knee. When you have this big inflammatory response with chondrolysis in the shoulder, you see this big idiopathic chondrolytic response to the shoulder. Nothing's ever stopped that. It's like a forest fire. It just burns out of control until all the cartilage is gone. And it leaves just destruction in its wake. No glenoid, and the only real surgery for it is a total shoulder arthroplasty. And we've actually been able to, through the administration of bone marrow aspirate concentrate, halt the chondrolytic response and restore some of the function and cartilage in that joint. No one had reported that. There's really no way to change the histopathology of chondrolysis. Once it starts, it doesn't stop until there's no cartilage left. Bone marrow aspirate concentrate's been able to do that. We couldn't exactly explain all the trophic factors and polypeptide uses and the microvascular support that it does that with, but that's what we're working on. And certainly looking at the bactericidal effect of that, which really we never even looked at as a company until we look at our data and go, wow, we haven't had an infection in our study. We have 500 knee scopes, not one synovitic reaction even, not even a draining portal, which because of our use of the PPP, when you spin down the bone marrow aspirate concentrate, we get these stem cells, but we also get this platelet poor plasma that has fibrin, fibrinogen, all these great clotting factors that help wounds heal, and we backfill our portals with the PPP. I haven't even seen a draining portal or a synovitic portal in the study group, in the patients that we've done. So, I mean, we have, and again, I'm in a small practice in a small town, right? We see all of our own patients follow up. They're not lost to the university. So between my PA and I, we are there for the dressing changes and the suture removals and the pre and post therapy visits. And we haven't had to take one of those knees back and do an irrigation debridement or open up the portals and wash them out in the last 3 years. And we're extremely busy. And that's uncommon. I mean, well, it really doesn't happen because I would love to think it's just a reflection of my surgical prowess, right? But it's not, because nationwide the risk of an infection with the knee scope is somewhere between 2 and 4%. It just is. You can do a great surgery. Patient has a swollen knee. It's like walking around with a petri dish in front of people sneezing. You know, you get a big swollen knee, you chew something too hard, you get a little bit of bacteria in your bloodstream, you get a little bit of a UTI, ends up in the knee, and you have an infected joint. In our bone marrow study, we haven't seen any of that.
So moving forward, could you see an application of bone marrow concentrate in total knees, total hips, where, to your point, you don't want that infection? Can I take that product and hope that my LL37 helps prevent
Here's the advantage of what we're really talking about, right? Even if we're treating a joint infection or someone has osteomyelitis, we leave antibiotic impregnated cement in that person, right? And it has to be there for 8 weeks. And we come back and take it out and wash it out again. And the antibiotics that you put in these people, they end up getting C. difficile or dramatic diarrhea or other co-infections because they've lowered their immune response to this. And so antibiotics are not inert. There's a significant amount of reactions to people that are on antibiotics too much or for too long or on the wrong antibiotics. Ask any female that's ever had a yeast infection following 2 weeks of antibiotics for a bad throat or pneumonia or a bad UTI. All those antibiotics lower your body's resistance to other things. Bone marrow aspirate concentrate doesn't. Not only do we get the bactericidal effect or the surgical protective effect is the way I think of it in surgery, right? So, because I'm not treating an infection with it. I'm trying to protect my wound, right? So we're doing surgery to make someone better. What we don't want to do is do surgery to make someone better and have a complication. What bone marrow aspirate concentrate's been able to do is lower our complication rate because it protects the surgical site, and that's not even why we're using it. We're using it because it absolutely accelerates the body's healing response to that tissue and acts to control your wound healing. That's why we use it. We use it because I can treat non-unions with it, and they've all healed. We use it in spine surgery because the fusion data says it's way better with bone marrow. Patients fuse faster, patients fuse more reliably, patients fuse more often with a lower non-union rate. This is all published data. This is 25 to 30 spine papers that have been published comparing stem cells to non-stem cell side, comparing stem cells with inert, tricalcium pyrophosphate kind of graph. Basically adding stem cells to coral, and got an equivalent result to autogenous iliac crest, which is the standard of care. And the complications of taking a bunch of bone out of your iliac crest or your hip compared to taking some bone marrow in a bone graft is dramatically different. So we're using bone marrow to lower the morbidity of surgery. Well, with our bone marrow concentrate, not only are we lowering the morbidity of surgery, we're lowering down the complications or the surgical side effects. We're actually acting cytoprotective. We're changing the physiologic response of the human body, which no one's even talked about. We hadn't even realized it. We've been doing this for 3 years and looked at data and went, we haven't had an infection. When you look at the data and say we don't have an infection, we didn't understand why. We didn't understand that was the case. Now, Arnie Kaplan, Neil Rorden, you get Neil Rorden on board with a company, and you get a lot more of the scientific side. I'm a clinical surgeon. I use a lot of bone marrow aspirate concentrate. We use a lot of stem cell product. We've invented an amniotic product with cell counts that will change everything, because the metabolic activity of our amniotic graft is 25 times the metabolic activity of anything else on the market that's legal in the US. And it's just a tissue graft. And when you add that in conjunction, or used in conjunction in a bone marrow aspirate concentrate patient for a surgical wound, we're changing everything. So when we last talked about the BMAC, we just had a product coming out. Now we have a year's worth of data and experience with the product. We have 5 different sizes. We have sizes that make it easier for everything from a foot and ankle specialist taken out of a calcaneus or a medial face of a tibia to 105 to reach right down the pedicle into a vertebral body. The 45, which is the primary catheter I use for anterior iliac crest draws. So we've literally changed the harvesting technique. We've developed the protocols necessary for people to use it. We recently recorded all the teaching videos, walking people step by step through the use of the catheter. We have a year's worth of data now that we didn't have before. So what we've tried to do with the BMAC is literally put bone marrow in the hands of the general surgeon, the general orthopedic surgeon, the plastic surgeon, the general surgeon taking care of a hernia that needs bone marrow on a mesh, and a patient that's had a previous infection and previous failure and doesn't have very good soft tissue. Now we're taking the uses of bone. Once you put a product in people's hands that made bone marrow accessible, and the surgeons see the difference that bone marrow aspirate concentrate with the mesenchymal cell volume and the concentrated trophic factors, once you see the difference that makes in the healing of a wound, the healing of a tendon graft, the healing of a non-union, a fusion, surgeons think of more uses for the product, because this is a product that we've just recently reviewed over 2,000 articles that are published on bone marrow aspirate concentrate and mesenchymal stem cell use. There's not one deleterious side effect reported in the literature. There's nothing that you can say that about. If you read the PDR about Tylenol, it says it can cause liver failure and death. So Tylenol can cause liver failure and death, but concentrated bone marrow aspirate concentrate has no deleterious side effect, right? And so we're talking about a significant review of the literature. It doesn't have an antigenic reaction. You can't be allergic to it. The key with our catheter is not only you're not going to have a reaction to it, but it's your own cells. We're using it for an autologous point of service delivery method, right? There's a drug being developed that's a concentrated allograft stem cell that's cultured, that's not approved in the US yet, that's meant to treat inflammatory response. There's a version that just got FDA approved in Canada for the treatment of graft-versus-host disease, which is a reaction to the treatment for leukemia that's 95% fatal, right? So they're proving that the stem cells make a difference there. And those aren't autologous stem cells like we have. Those are allograft. But in an allograft stem cell, you don't even have to be blood type specific. You don't even have to be male to female specific. Type O, type B, those don't matter in the stem cell world. The mesenchymal stem cell is an undifferentiated, non-allogenic, non-antigenic tissue. And so the amniotic membrane stem cell, the amniotic MSC, doesn't have an abnormal reaction in the human body. There's not an allergic reaction. So there's no tissue as a tissue graft that you can report that. And we use xenograft. We use pig tendon to insert for rotator cuff repairs a lot, right? As a tissue graft, because we need structural support. There was a patch that was, it was actually called Pegasus, that was an equine tissue. There was a significant amount of reactions to it. It was on the market for a while. It's off the market. A lot of repercussions of using tissue grafts. There's not a lot of tissue grafts, which is what marrow is, which is what our amniotic product is, that don't have a deleterious side effect, and that's never been reported. So the advantages now with a year's worth of data and finding out more about what we're doing, we just talked about the antimicrobial effects. We didn't know that a year ago. We intuitively knew it. It made sense. We didn't have the peptide isolated. I hadn't heard of LL37. That's certainly not the reason that we developed the catheter. We developed the catheter because we know bone marrow can help generate tissue growth and lower the complications and failure rate of other surgeries. We were literally just trying to lower the failure rate. We were trying to grow cartilage and an osteochondral defect. Because again, review of the literature, osteochondral defects have been healed with nothing but marrow aspirate concentrate and stem cells. There's rabbit studies published, there's murine studies published, there's equine studies published, there's a sheep study published, there's baboon studies published. So we have studies published, mammalian models, showing osteochondral defects, chondrogenesis with mesenchymal stem cells. There's just not a human study published. We've been using it in humans for almost 5 years because we know it changes the health of the tissue and the joint, which is what we're trying to do.
The value of the concentrated marrow added to the right inductive conductive material gives us a greater product than, say, an OsseoCell or a Trinity product that are trying to enter the marketplace as a stem cell based product. Tell me how the BMAC combo with a carrier is more potent or more efficient than an OsseoCell or a Trinity.
Well, here's the problem with all the other grafts on the market right now. They don't have the cell counts that we can achieve with our graft. They don't have the trophic factor support that we achieve with the concentration of bone marrow. So it's the access to bone marrow, the BMAC, not having to pound a great big jamshidi into someone's iliac crest and run the risk of abdominal puncture, run the risk of an arterial vascular injury because you have a big nail, run the risk of a fracture to the ilium, run the risk of a chronic sinus draining from the ilium, because you get, or even the most minimal side effect of a jamshidi, a big subperiosteal hematoma, can cause pain and problems for 3 to 6 months. We haven't seen a subperiosteal hematoma using the BMAC because the way the tip is constructed on the BMAC, and I'm sorry I've drifted away from your question, but I'll get to it. The way the tip is constructed on the BMAC, it's made to make its own pilot hole. We're not inserting a drill down into the ilium, where it's removing bone and debris as you put the drill in, and you're meant to drill a hole almost real time. The BMAC is designed as an interosseous catheter. The reason it has this perfect, sharp, diamond tip support is not to act as a drill, but for it to act as making its own pilot hole for the delivery of the catheter. So, but it's not a drill, it's not fluted. It is a diamond-tipped catheter because when you put this in, it needs to form its own pilot hole for the delivery of the catheter. It's not, we didn't make this. You don't take a drill bit and impact it into an iliac crest. We don't want you to take the BMAC and impact it into an iliac crest. What we want, and the reason we've designed it this way, as you start to drill the catheter in place, it forms its own pilot hole. The pilot hole acts to secure the catheter in its position so it doesn't cause an untoward effect of wandering into the abdomen or wandering outside the pelvis. It gets, you put the sharp part of that where you want it, acts as a pilot hole, forms its own area for it to seat, and then you can advance it as it creates the hole. A big drill bit, a big fluted drill bit, would actually cause platelet cell activation and trauma. It's like stirring everything up in a blender. Putting a drill bit through the pelvis causes turbidity. Turbidity causes clotting. Clotting would cause your cell count to go down. The reason we designed the catheter like this is we don't want to create a lot of turbidity. We want to create a round hole. We're not trying to drill all the way through something. We're trying to create a round hole for the delivery of a catheter for harvesting of cells. So its design is very specific. You don't need a lot of change in what we're doing with it. You know, taking a mallet and impacting a catheter in place, taking a jam sheety and impacting it into place, what we're trying to do is get a really high quality aspirate. We're trying to teach people how to do that. The way to do that is to avoid platelet cell activation. The way to do that is to lower your turbidity and trauma of the draw. The way to do that is to draw in the right locations. The way to do that is, if you're not getting the marrow you want, reposition your catheter a little bit. The way to do that is to pay attention to the amount of concentrate you want to get. We don't do a 30 cc draw when you could have done a 90 to 120 cc draw. That's the whole reason we created the spin process the way we have now, is we're not spinning 60 cc's at a time. We're spinning 90 to 120 cc's at a time because we want higher quality cell counts with more concentrate. So, you know, I laugh every time I see that AT&T commercial with all the little kids. Well, why is more better? Well, because sometimes it just is better, right? And especially when we're talking about growth factors, healing response, cell counts, microvesical support by the mesenchymal stem cell, that's what we're trying to look for. That's what we're trying to do. So the design of the catheter is created on purpose. It's not meant to be a drill bit. It's meant to be a delivery device for harvest. We're trying to deliver a catheter to get access to bone marrow for normal surgeons.
So the value of my marrow goes to the carrier that we choose, that goes to being a better product than an osteocell or a Trinity, because I'm going to stack it. I'm stacking the deck in my favor.
Yeah, osteocell and Trinity aren't delivered in a slurry of trophic factors, right? It's a limited allograft cell, which allograft cells are great if you got 10 million of them, and they're amniotic and undifferentiated. That's not Trinity or osteocell, right? What would be the perfect allograft would be something that could give you 25 times the metabolic activity of a Trinity with an amniotic, undifferentiated mesenchymal stem cell. Think of adult stem cells and amniotic cells as the difference between a great, big, robust, brand new grape just picked off the vine or a raisin. Which one do you think has the most healthy cellular support? The raisin, which is a 40, even the newer products we're talking about that are being administered as drugs, those are made from adult cultured mesenchymal stem cells. They're not the healthiest stem cell. The healthiest stem cell is this big, nice, robust mesenchymal cell from an amniotic tissue, which is maternal tissue, not fetal tissue. It's the placenta. It's what's delivered out from, it's what mommy gives us after the baby, right? It's medical waste, but it's also the key to helping wounds heal. It's the key to reducing chronic inflammatory changes around tendons. It's the key to adding cellular support and structure to the tissues. acellular tissues. We're talking about using bone marrow aspirate concentrate and stem cells and rotator cuffs. Every shoulder surgeon has, on a redo cuff, someone that had a cuff repair years ago, and then they tear their cuff and you're going back in to fix it. And you look at the cuff tissue that you're supposed to be fixing, and it's white, it's atrophitic, it looks like the fascia around a steak. There's no cellular support, there's no cellular volume. It's not like fixing a nice healthy tendon back to the shoulder. You look at this tissue and it has almost no cellular structure. It's collagen type of tissue, but it doesn't have the cellular support. Well, how do you get that to heal? Well, traditionally in orthopedics, we decorticate the top of bone because we want to get down to the marrow, the active area of bone that can heal, the subchondral tissue, right? You don't fix it to the cortex. Cortex is inert, very inactive. Soft tissue won't heal to that very well. So you decorticate, take the top of that bone off, and you sew this tissue back to it. And now we're asking these cells from this bone, from that marrow that you've sewed it to structurally support into that tendon. Think of this atrophitic old rotator cuff tear like a trellis with no vines on it. Well, we're asking this bone marrow cells to incorporate itself and grow up into that trellis. It's a long, torturous process. And not only that, if the person's in their 70s or 80s, the average age of rotator cuff tear is in the mid-50s, but it's really common in the elderly. So you get this cuff tear, and the tissue that you're going back in to fix it has the structure of a thick piece of gristle that tears apart. Well, what we can do is we want to add, now we have this great collagen matrix that the body has already structured to help support cell structures, but there's no cells in that. So we can repopulate that tissue, or that graft. And in my mind, I think of that as a tissue graft. The human body, the patient is supplying my tissue graft, but it's a tear. I got to put that tissue back where it goes, and it's already crummy tissue. So that's our tissue that we have to work with. But I've been very easy to intuitively transfer the data that we've accumulated from doing grafts, which there's a published paper on use of biologics, autologous biologics, on ACL grafts that show grafts treated without biologics took 369 days to heal. And by heal, we mean return homogeneity on an MRI. And homogeneity on an MRI is already described as healing. All right, there's other papers that have already presented that, right? So we don't even have to argue about, well, how do you know it's healed? Well, homogeneity on MRI is a good marker to judge that by. So without the use of biologics, 369 days to 369 days to homogeneity on MRI. With the use of biologics, and they just soak the graft. With the use of biologics, 179 days. So 369 to 179. So 48% difference in the time to homogeneity of healing on the MRI. Now, why does it, and that's with the graft taken out of the body, completely separated, and then put back into somebody, and then being able to see the healing on MRI. Rotator cuff tissue already has a better chance than that because it attaches to some blood supply, but a lot of it's atrophitic and crummy, especially in a diabetic elderly patient. But if we can take their cells, their cellular support network, the bone marrow, and honestly, if a few drops of bone marrow work, the whole key is what does the concentrated equivalent of 120 cc's of concentrated bone marrow do, right? Now we have some cellular support. Now we have trophic factors. Now we have VEGF, FGF, transforming growth factor beta. We have this network of fibroblastic growth factor. We have the tissue responses we need to help a wound heal. And because it's bone marrow, not fat, we have the hematopoietic potential. So now the hematopoietic stem cell helps signal angiogenesis. So we are getting new blood supply to healthy tissue and providing cellular support. And there's papers published that show in non-union proximal tibia fracture where there's a pre and post arteriography of that non-union showing there's almost no blood supply around that fracture site. 6 weeks after nothing but concentrated bone marrow aspirate injected into that fracture, and all they did is inject it around the non-union into the gastroc because they were looking at it as a limb salvage. 6 weeks later, arteriography showed dramatic collateral circulation around that non-union because of the angiogenesis caused by the infiltration of bone marrow concentrate. And that was a year-old fracture. So it's not that it's just the time that all of a sudden angiogenesis started. Angiogenesis had gone away. There was no blood supply around that fracture site. 4 to 6 weeks, I think it's 6 weeks is the post-op arteriogram. It shows dramatic collateral circulation around that. And we have all those articles. We have all those articles in our data bank that's accessible to our surgeons. So we can show you what an arteriography looked like pre and post use in around a non-union. I can show you and intuitively know then that that's the same thing that's happened in the other tissues in the body we use it around. When you get this cuff that doesn't look like it has any blood supply and doesn't have any cellular support, and you take this bone marrow concentrate and you pepper that tendon with those cellular support, and you inject underneath this area, and you create this soft tissue graft of live, healthy tissue into the dead atrophitic tissue, you can bring that tissue more cellular support. And that's what we've been using it for.